We have an illustrious panel here of many thought leaders and also very people on the ground. I'll briefly introduce them. We have our very own Dr. Natalie Pagler, CMIO of the Children's Hospital, is very forward-thinking about all the things about how do you integrate computational methods into actual clinical practice. Student Dr. Celine Everett, a first-year medical student. Before she came here, she didn't care about AI, but suddenly she might be realizing and thinking about what does that mean for her education, that she is paying for the privilege to be here. We got to make it worth her time. And next we have Dr. Carolyn Kaufman, probably one of the best medical residents I ever worked with, who taught me a lot about AI, because I don't know what this stuff is, but she's on the ground using it. And we also learned a little bit together on what they can and can't do on the fly. Dr. Bryant Lin, really privileged to have you as a physician, as an educator, as a patient, and really an inspiration to a large community. Really grateful that you're here to give your perspective on all of those. Dr. Carla Pugh, I said, wait a minute, we have to have a surgeon on this room, because all these medicine people, we're definitely the ones being replaced by computers, but surely some surgical procedural skill can withstand the AI revolution. She'll tell us more on her perspective here. Dr. Malathi Srinivasan, Latha Palaniappan once told me, you know, when I have a trainee and I need to turn them into a professional, I send them to Malathi. So I want to know, what does that mean, and how do you make that happen, and why can't we learn from a book? And finally, Ilana Yurkowitz, with a perspective as a doctor, but also a journalist, ethical perspective, I think has a perspective both from the inside and outside. Please take it away. I'm going to defer to Dr. Natalie Pagler to drive the moderation.
Thanks, Jonathan. It's been an amazing few days and definitely an amazing afternoon. Lots of questions have been raised over the last couple hours, thanks to our speakers, and we're going to answer them all for you. We've got all the solutions, easy. So even though Jonathan did such a great intro, I'm going to start with having us all introduce ourselves in a little bit more detail and answer why we agreed to be on this crazy panel when Dr. Chen reached out, and basically why do we think this is such an important question and conversation. So just to start, I will be doing mostly the moderating, but I'm the Chief Health Informatics Officer at Stanford Children's and a pediatric ICU doc. I also have a master's in medical education and co-founded the Pediatric Clinical Informatics Fellowship. We've gotten to see a bunch of our current fellows and alumni today in the last couple days. So I've had the opportunity to think about education from a lot of different perspectives, and now I'm confused more than ever. So I agreed to join so that I can learn more from all of these brilliant people.
Hi, everyone. I'm Celine Everett. I'm a first-year medical student here at Stanford. And the reason why I'm on this panel is because when I first came to Stanford, I took a class with Dr. Chen, and he showed all the graphs of ChatGPT outperforming doctors. And I thought, well, I'm here to learn how to be a doctor and how to pass these board exams. And so I kind of jumped into doing research on how doctors can use these tools better and how we can maybe be better than either alone together.
Well, hi, everyone. I'm Carolyn Kaufman. I'm a second-year internal medicine resident. In a few weeks, I'll be a third year. And I agreed to be on this panel because at this point, I'm using AI pretty much every day to do my job as a resident. And I'm simultaneously excited, but also kind of terrified about what AI means for my future job and my future career in medical education. So it's great to be here today.
Hi, Bryant Lin, primary care. I'm on this panel for two reasons. Number one, I will do anything Jonathan asks me. And number two, anything Jonathan does is worthwhile. So that's why I'm on here. But I'm also the co-director of the Biomedical Ethics and Medical Humanities concentration for the medical students. I teach residents in clinic, and I also teach a class called Generative AI in Medicine.
Hi, everyone. Carla Pugh, and I am an acute care surgeon, and I'm here because Jonathan knows that I suffer from depression because I've been waiting for the Star Trek holodeck for 50 years. And it has not materialized, and I'm waiting for AI to just make it happen. Seriously, I've actually spent the past 20 years studying human performance, using sensors and motion tracking and any type of technology that I can get my hands on. And I'm pro-human. Human beings are ridiculously complex and amazing, and when you digitize them, oh my goodness, more to come.
Hi, everyone. I'm Malathi Srinivasan. I'm a clinical professor here in medicine and also a medical educator and health services researcher for more years than I would like to admit. I think that I'm here for the same reasons everyone else is, because first, Jonathan's awesome. And also because I think that we're going to face two central challenges. And I think the first one is to architect a new system of healthcare delivery and a medical education system to match that will initially, in the near term, incorporate AI in the elevated, wonderful, exciting ways that we've heard about today that will augment performance. But in the long term, the central challenge, I think, is going to be understanding the disintermediation of the physician and what that's going to mean for our educational practices, and at the same time, creating the physicians and the workforce in healthcare that will help us understand how to make sure we still have the judgment and skills to take care of patients when the technology doesn't perform as expected.
Hi, everyone. I'm Alana Yerkowitz. I'm an internist and oncologist by training at Stanford, and my specialty is cancer survivorship. I'm also a medical journalist. I'm the physician journalist in residence at Stanford, and I wrote a book that came out 2 years ago called Fragmented, A Doctor's Quest to Piece Together American Healthcare. And a central topic of that book was how our electronic medical records are so disorganized that my thesis that doctors were working in a constant state of being partially blindfolded to the full details of their patient's story, and at the same time, patients are saddled with putting the pieces together. And the book was delayed for a few months, and I promised my publisher that fragmentation would remain a problem, and there was going to be no Deus Ex Machina that would come in and solve it. And I think I used the words artificial intelligence one time in chapter 3, and that was it. And so I'm excited to see and explore with everyone today kind of the state of fragmentation today in 2025 with the advent of these tools.
Awesome. Okay, so lots of different perspectives, and I think already more questions being raised than answers, but we'll keep working on it. So why don't we start with thinking about what are the core competencies of a physician and or surgeon, and how might that be evolving or affected or augmented by AI? So we've got representation from, we've got some physicians, we've got our surgeon, we've got a couple of trainees and trainee physicians. Does anybody want to start with one of those three personas and go first? Carla, you want to do a surgeon or you want to do that last?
I'm always okay to go first. I
Do
just
it.
don't
Let's
like
do
being
it.
a stage hog
Let's
because
talk
I
about
like to
surgeon.
talk and tell stories, and Jonathan knows that. But sure, I'm never afraid to start. When I think about the core competencies of a surgeon and comparing it to what AI brings to the table or can do, I can say that, I mean, there's a team aspect. You can't be, as a surgeon, you're part of a team that works in a very complex, dynamic environment that's taking in so many inputs. And when I look at all of the way that AI has been described in this room today, I still think of it, I think of it as something that we're feeding information to, but it is not context aware, and it does not take in all of the inputs that I take in, or any of my colleagues on a regular basis. So when I think about the core competency as being a part of a team, when I think how I value it, it's that I'm a valued member of the team and I bring some base knowledge that is of value and my own experiences. I am constantly adapting to the environment that I work in. The cystic artery is not always in the same place that Netter said it would be. So you can't train AI to do what I do because you're going to use a GPS system of the human body that changes. Our cars would all be crashing if the roads changed every day, every minute, every moment. So when I think about what AI can bring to the table, I am excited about a few things in that the job we do is hard enough. There's so many things we need help with. And if we can train it to do some of those things that we actually don't need to do all the time, I think that we can actually evolve and be even more cognitively in tuned to this constantly changing environment. And so that's where I do believe in the human AI relationship. And I'll end with this. We've also talked a lot about how do we train the future physician to work with AI. I want to hear more about how we train AI to work with us. Opportunities.
That question. All right, so we've got a starting answer and talking about the importance of a team, and maybe we'll get to, is AI a member of the team in the future? How about any other perspectives from any of our practicing physicians that you want to add in?
Well, I completely agree with Dr. Pugh that it's hard enough being a doctor that we don't need to add any additional hurdles to our plate that doctors shouldn't be doing. And so maybe I can just take a step back and speak briefly about the state of the landscape today. Doctors are not being doctors now. So I'll cite some scary statistics that are up to date from when my book was published in 2023. The number one source of burnout for physicians is bureaucratic tasks. And this has stayed true before and during the COVID pandemic. It has stayed true after the COVID pandemic. It has stayed true across different specialties, whether you're in surgery or internal medicine or oncology. Another study came out last year. If primary care doctors did everything they were supposed to be doing in a day, they'd be working 26.7-hour days. What percent of that is paperwork? What percent of that is interacting with disorganized and cluttered electronic medical records? Very high percentage. Another statistic, for every 8 hours spent in clinic seeing patients, doctors do 5+ hours of charting. So when do they do that? They do it when they're in between patients. They do it when they're in front of patients. Everyone in this room has probably seen their doctor looking at the computer screen instead of them, or they take it home with them. So my biggest hope for AI, it doesn't sound very sexy, but it's doing all of this other stuff that doctors are doing now that I don't see we should be training medical students to be doing, but just need to be done in order to move care forward for patients. And it sounds like boring stuff. It's paperwork, it's bureaucratic tasks, it's doing phone calls and getting prior auths and being on hold with insurance companies and fighting payers. These are all tasks that we do, and they're all tasks that take an inordinate amount of time that need to get done. And there was an article in the New York Times recently that said how AI is being used in healthcare the most right now, administrative tasks.
Absolutely. So let's take that one a little bit further, right? So let's pretend like our ambient scribes, just become perfect, and we've got robotic process automation doing all that prior auth for us, and we get rid of that administrative task. What are we left with? What are the core competencies of the physician that they should be doing?
There are, in preparation for this panel, I had spent time speaking with a lot of the engineers and product developers at FANG, which is Facebook, Amazon, Netflix, and Google, plus people at banks, as well as people who are running healthcare systems, to really see where they thought the future of AI was going to be. And if we can actually get back to being doctors, which would be absolutely amazing, and use the AI as part of the healthcare team, what would that look like? And where are the pitfalls? So I think that there were several things, right? So the first thing I think, what makes a doctor is judgment. And we've heard today about how some of the tools that are being currently developed can enhance our judgment, make learning more efficient, make it faster, better, smoother, bigger, fly the plane in different directions more quickly and get to our destination more rapidly. But then the biases that come in to the AI because of the inputs that are being developed, where is the data coming from? There's no transparency in the majority of models that are being used for us that we are given about what data sets the AI was trained on, what the validation set was, what the output was, and how accurate it is, and how there's a drift over time. We know this happens with all of the models, but we don't have any transparency about that, and there's no real regulatory standards yet that are going to protect us and protect our patients. So a part of the judgment in utilizing AI in practice is going to be to have sophisticated users of the technologies so that we can actually ask and answer those questions, and we know the limitations and the biases for all of the information that we're getting. The second major thing, I think, is going to be as AI gets better and the hallucinations go down, and there's an opportunity. Right now we're talking about agentic AI and we're talking about generative AI, but what happens when there's aware AI? We're talking about deliberate misuse of current generative models, but what happens if there's malicious AI? What happens if we need to turn the models off? Will we still have a physician workforce and a healthcare workforce that's capable of carrying out the kind of sophisticated care that patients need without the technology? And I think those are real issues that we need to confront.
Yeah, the automation bias and automation complacency, and what do you do when it gets turned off is like one of my favorite topics that you go on. But I think Brian's got some things to either add or rebut.
No. Just always to add,
Okay.
never to subtract. Just curious, how many of you? So we asked this question in our class a couple of years ago. It's okay. I'm going to kick that over before the end of the session. So, how many of you would be comfortable seeing an AI doctor? Let's fast forward 5 years. AI is really good. Receiver operating curve, just as good, better than physicians at diagnosis and treatment, and we could get there. It's already good at multiple choice questions. How many of you would be comfortable seeing an AI doctor for something simple? Sore throat, urinary infection. Pretty impressive, right? And the average age in this room is probably a bit higher than in my classroom. Let's say that. Okay, we're still 5 years in the future. You have stage 4 lung cancer. I have stage 4 lung cancer. How many of you would be comfortable having that AI doctor take care of you? Yeah, many fewer people, right? And again, there's no absolutes in this world. I would not be comfortable. Sorry, I'm going to call you out, Dr. Wakely. My oncologist is back there. I would not be comfortable because to me, medicine is about, and I'm speaking as director of medical humanities. Medicine is about human connection. I've been seeing the same patient. I've been at Stanford for 20 years. I've been seeing the same patients for almost 20 years. I've attended the funerals of patients. I've sat by their bedside. I can tell you, AI is not going to be there when you're taking your last breaths, and you're looking for comfort. Okay, you're looking for somebody to talk to, to talk about life, to talk about living. So to me, medicine is at its core about human connection. It could be physical human connection, connecting. Dr. Pugh literally connects with people's guts. I mean, literally, right? It could be emotional and spiritual connection. I'm not wrong, right? You're connecting.
I was waving at everyone's intestines. That's why.
And of course, we could always argue about robots and the future of robotics and everything like that. But, you also connect with people, them as a person, it's going to be hard. It's much easier to talk to. When I was getting a bronchoscopy, the fact that I knew who was going to be doing the procedure, I connected with them as a human being was so important to me. I personally cannot connect with a robot, with an AI that way. So when I look forward to, hopefully never, but the time when the time comes for me, that's got to be a human. Everything we do, all the technology, all the amazing work, Jonathan does, that you do, that everyone on this stage does, to me, that's just in support of that human connection, the doctor-patient, the caregiver-patient relationship. So not even provider-patient, but, the family, how they work together. So to me, that's the core competency of the doctor, is really that human caregiving side.
I can't be quiet anymore. I love what you just said, Brian, and this is real because you're a real patient. And
I wish I were a fake patient.
When I'm listening to you, my thought is, yeah, you've got a good one. You have someone who has an amazing bedside manner, right? So, there are instances when, how many of those of you have had a physician that actually did not communicate well? That's actually kind of common. Not of Stanford, of course, not at Stanford. For me, the whole time I'm looking at this argument, and I never thought I'd be like putting tokens in Jonathan Chin's camp, but because I'm like paid to be the contrarian. But when I'm listening to what you said, Mallory, and what you said, I'm thinking, it's not a zero-sum game. Why can't I have both?
Oh, I
Why-
totally agree. Yeah.
Why can't I have both? And having AI there, it's time-free, space-free, it's free. It's going to be, it can be there talking to me. It could learn me and what I need and help me through that, and even maybe prepare me to have a better relationship. On the flip side, I'm thinking it can also make all of us better. When I say all of us as healthcare practitioners, it also help us be better at the human interaction. I mean, a lot of the things we struggle with is because we're trying to obey some rule that shouldn't exist or that we misunderstood, and then we're having that outward-facing presentation of ourselves. And then we fail at at the human interaction. But I think AI can notice that, it can track it, it can help, it can be the, I don't know, I feel like it can
Help
make
us
us
be more
better
human.
in doing that. But I'm still
But,
thinking we can
it's
have
the
both.
tool. So I agree. I'm not. All the tools and technology in service of supporting the human connection. I don't see a world in my hope where there's no human interaction, where there's a proxy for human interaction.
So let's,
I'm going to push you on that a little bit, Brian, because if you think about the number of people who need care and the volume of care that needs to be delivered, and you think about the maldistribution of those resources, not only in this country, but around the world. We have countries in some developing nations where there might be one physician for every 10,000, 100,000 patients, right? And then they're augmented by community health workers, mid-level providers. The promise of AI to be able to provide that base level of rudimentary and then potentially even next step up of care is pretty amazing. And so for those of us who are lucky enough to be in health systems like this, where everyone's pretty awesome and it's easy to talk to people and we still have that human connection, they can access us. But to access someone who is fairly skilled is actually a bit of a privilege. And so I think that the promise of these technologies is they can extend us in ways that we probably don't even understand right now.
so I think it's some really lovely points, and I think we're going to get back to this human connection piece and what it means to be a human connection and physician versus AI empathy versus another care provider. But I'd love to just take a minute to go to the other end of the spectrum and like looking forward, just decided relatively recently to go into medicine. What was it that made you two go into medicine, and what was the core competencies that you expected to learn by going through medical training? And is that evolving at all?
Well, it definitely wasn't the paperwork.
What?
The administrative tasks.
love
But
writing
anyone
notes.
who's been a resident knows that is actually a lot of what you do, especially intern year. So it makes a lot of sense, especially from an oncologist, talking about the amount of paperwork and records that patients have. And that's where AI has been most useful for me so far. I was on oncology outpatient rotation a couple weeks ago, and when patients come to Stanford Oncology, typically it's for like a third or a fourth opinion, and they have a very extensive medical history with a very extensive records. And it falls on the residents or fellows oftentimes to sift through those records. There's a lot of redundant, maybe irrelevant information, and try to put together a history, a relevant summary of the patient's history. So if you look at an oncology note, you'll see a lot of times at the top they have by date every single important event that happened for that patient, starting from their first symptoms to the different diagnostic tests and therapeutics that they had. And it's really useful to have, but it takes a long time to do that. So I found myself taking hours to read through these records that are from various hospitals, and it's not a very fun task. It's tedious. And so I thought I should just try to put this into Secure GPT, the Stanford Secure Chat GPT that we have here, and I asked GPT to do that, to create a chronological oncology history, and it spit out an amazing summary. And so my task went from multiple hours of tedium to a really very quick few minute worth of pressing buttons, typing in things, and then I could actually enjoy the medicine, reading through that patient's history, double checking, seeing if it was relevant. And then when the patient came in, I went through that with them and asked if it really was accurate. And then you get to spend more time with the patient, talking to them, instead of having to sift through all of these records. So I think part of honestly what weighs on trainees a lot of times is that when, to your question about what makes you a doctor, it was none of us dreamed about going through all this paperwork. And so AI has been most powerful for me, at least as a resident, and getting rid of that, and instead doing what I dreamed of doing when I was a doctor, which was talking to patients, getting a history, doing a physical exam, forming those connections with patients, and then thinking about the medicine, like really diving into understanding what's going on with them and discussing with my colleagues the pathophysiology and having fun thinking about what would be the next steps for this patient.
Love it. And Celine, along the same lines, that I both would love to hear what you went, like as you're just starting med school, what are you thinking you're going to be? What are the core competencies you want to learn? And then also hearing like this conversation about how residents are starting to use AI. I know you've started to think already a lot about what we should be training medical students around AI. So I'd love to hear your thoughts there.
Yeah. So before I went to medical school, I spent a lot of time with Lyme disease patients, specifically chronic Lyme. And a lot of what I saw was the difficulty to hold uncertainty from the patient side. And so learning as a physician how to hold that space with patients, which is something that an AI tool can't really do, human to human, person to person. And so what I've been really excited to be here to do and to do research on is how the AI tools can help doctors kind of in a complementary way. So I know some limitations were brought up about data sources and data biases, but also thinking about workflow integration and what comes from that, and thinking about these AI, like some people are people pleasers, AI is also a people pleaser. And so thinking about it wants to agree with whatever you say. And so if a doctor builds a differential and puts it into the AI, we found in our study that half the time the AI will just agree with whatever the doctor just said. And so as a medical student, thinking about, okay, when I'm building up a differential, I should let the AI go first and let the AI build its own differential and give its independent analysis to me before I think about, if I trust it or not, or I agree with it or not. And it's interesting also because we heard from Dong about how important it is to build instructions for these AI prompts. And one of the studies that I've been working on the last 8 months now, it'll be on medRxiv this week, is we built a system prompt with very clear instructions for the AI to give its, quote, independent analysis. And half the time, it just regurgitated what the doctor said. So even if the instruction is clear, it's lying to you when it says its independent analysis is, and then the 3 differential diagnoses. So that's been a large part of what I've been interested in this year.
Wow, so medical education is changing fast, because that is not something I had to learn in med school. So let's go back to, there's so many different directions we can go, but let's go back a little bit, because I heard I think almost every single one. We know it's not administrative work. That's not why we went into medicine. But we heard a lot about human touch and empathy and connection, and yet non-physicians can demonstrate some of that. And then we've seen all of these studies around the empathetic responses of LLMs. So what distinguishes that human connection and empathy for a physician versus either the LLM or other care providers?
I'll give a short one. It's in context, and I was just sort of thinking about that as I'm listening. As a physician, you have this base knowledge, disease-specific knowledge, and you go to talk to a patient, and you're gathering information to see where you are in the decision tree. But at the same time, you're talking to a real person. You are taking in other inputs. You're looking at their face. You're looking at their clothes. And if someone is disheveled, and visual inspection, real time, that I am getting a sense of, if I come up with a treatment plan, is this patient actually going to be able to execute it? who are their family members and what do they look like? Like I'm doing real-time calculation of the success of the treatment protocol that I'm going to suggest, and I am adapting and adjusting that and adding additional team members if I think there's a big gaping hole in what I'm thinking I can do with this person. I don't think AI can do that real time yet.
So I agree with everything that's been said so far, so definitely not subtracting anything either. Certainly what AI can't do is bring their personal experience to a care interaction. And I can say as a physician, I sometimes bring my personal experiences to patients. I don't think it detracts from the encounter. I think it validates people. And as a patient, I've experienced that too. When I was recently pregnant and had a pregnancy complication, my OB said, I bled when I was pregnant too. And that really helped me get through what was going on because it was a real experience. It was authentic. And I appreciated her bringing that perspective in. And I think there's also been a lot of good conversation about potentially adding AI as a team member, which I also agree with. And I think some of these conversations are familiar. We're talking about what makes a doctor a doctor. I remember when we talked about APPs coming into medicine, and there were certainly members of the medical community that were clutching their pearls then and saying, well, like they were trying to figure out what makes a doctor and why are APPs encroaching in our territory? And guess what? They're not. Medicine works best when you work in a team because, like what Brian mentioned, everyone wants to see the type of care that Dr. Wakely provides. But Dr. Wakely, not to put you on the spot, I'm sure your wait list is quite long, and I'm sure your access is not great because you're such a great doctor. And so what people need is risk stratification. Like, when do you see the Dr. Wakely, and when can you ask AI for help self-managing symptoms, or even just triaging? Do I need an appointment, or can I self-manage this at home? Or can I see urgent care? Can I see an APP? And there's a lot of potential for lower level things that don't require the care that Dr. Wakely provides, because we are living in the real world where there's a crisis of access. And everybody's wait list is about 6 months at Stanford and otherwise. So I think thinking about these tools have to take into account the realities of how many physicians there are, what the shortage is, and then what the demand is from patients. And sometimes it's just getting people to the best they can, even if it's not the perfect level of care, because that's what people need.
And the promise of AI is pretty profound. A couple years ago, Rusty Hoffman in radiology had very kindly invited me to participate in one of his projects in which we were trying to develop a visual AI that could tell whether someone was sick or not sick when they came into the emergency department. And now you may say, for those of you who are not in medicine or who are just early in your training, this is actually one of the hardest things to do, is that eyeball shot of judgment, the blink biopsy. Are you sick or not sick? And we collected data on several hundred patients, I think 500-600 patients in the ED. And actually the final AI model that was built was actually able to discriminate, as well as a nurse could, whether someone was going to had a higher likelihood or a lower likelihood of being admitted, either to 23-hour OBS or to the hospital. And those kind of triaging tools, so who needs to be seen fastest? We can use the tools as a collaborator or as a triage or in whatever way to be able to help us figure out what to do next. And then I think it's still that nuance, that complexity, that judgment, that connection, that trust. And then there's such a large regulatory environment that we haven't figured out yet. What happens if a malicious actor starts to hack all of our data? These are very private conversations and things that we have with our patients. Can we actually trust the information systems to stay secure? There's real questions now in the community about the limitations of privacy. So when you're with that physician and you have that private connection and you have that moment, and you say, don't write this down, you don't, right? So you have those moments where you actually can go beyond what the technology can do at least right now, maybe not so much in 15, 20 years, but at least right now as we prepare for this evolutionary system that's going to foundationally change every aspect of everything we do in healthcare. I think these conversations about connection and humanness are going to be, I think, central to that. But so will complexity, nuance, and trust, and precision.
So much to keep in mind. I'm going to pick up because both of you, I think, touched on. There's so many pieces there, but the authenticity piece versus like the empathy, and it brought to mind. I remember I had a friend who knew that his patient had had a new grandchild and took the time and wrote a note and said, "Hey, congratulations on the birth of your grandchild," and got this nasty, angry note back. "I don't appreciate your AI sending me auto-generated notes, blah, blah, blah." And he's like, "It was me," right? And so, again, there's multiple different themes we talked about, but what is that authenticity, and how do we train that in future physicians? How do we train that professionalism? Any thoughts about that piece of it and why it's important, and what do we need to make sure that we don't lose in medical education?
You just bring up another topic for me as I'm like, real time, how do you train authenticity? It's crowdsourced, right? Because my authenticity and how it presents is different than someone else because of their origin story and where they're starting from. And so I'm going to take from, the 20 or 30 attendings that as a trainee that I'm looking at, and I'm going to take bits and pieces of the part that I like that fits me, and then I'm going to then portray that and then perfect it over time as I learn more. So I think that's the one part, again, that's coming up in what makes you a doctor. It's you. It's what you bring to the table. It's the variety. It's, your contribution to the team that's special, that makes the workplace environment amazing. I don't know. I think you show up your best self, and then have that conversation with the students and residents in terms of what you see in them.
Do you both? Do you know what your authentic presence is as early trainee? How do you develop that? How do you become the doctor that you want to be?
I think watching my attendings do their job as well as they do shows me the kind of doctor that I want to be, and the care that they take in teaching us how to become a good doctor just shows how much they care about continuing patient care to be the best that it can be.
Yeah, I think you also get feedback from your patients as well as you try out, different ways of having discussions, and then you kind of see what works well, what doesn't, how things come off. Sometimes not, you don't mean to come off a certain way, and then you do. But definitely attendings as the first role models, and then, patient interaction, talking with the patients.
I think in addition to the role modeling, I think it's really, to me, maybe I'm a simpleton, but to me it's just about treating the patient honestly not as a patient but as a human being. So it's hard when you start out, right? It's very formal, very a little bit stiff, right? When you're kind of a trainee or a student or even early attending, and then you kind of get in your groove over time, and to me at least, I realize it's because I'm really treating the patient as a human being rather than thinking of them as a patient. And, that enables, I don't know if authenticity is the right word, but maybe just, a genuineness about the approach.
Another thing I think that AI, at least in the foreseeable future, is probably not going to be able to do is know what's not being said. I'm sure that we've all walked into a room with a patient and you can tell they're just uncomfortable. And it's not even the door on the doorknob, hand on the doorknob moment where you're about to leave and they tell you something, but it's what they're really not saying. The underlying source of their problems that need to probe, that need for them to connect with you so they feel comfortable enough to tell you what's actually going on in their life. And so the models that are being built on either EHR data that is now being using natural language processing and the LLM models dissecting all of those, which has been pre-digested by a physician or by someone else in healthcare. So you're getting pre-digested information from the raw patient information, from all of the cues that everyone's been talking about that you get when you're with someone. So that initial interaction, that human interface, has not been explored very much yet. And I think that those are the moments and those are the times of what's not said, what's said, but what's wrong, right? People will tell you things all the time that just are not true. Not all the time, but sometimes. But we can distinguish those things. And so it could be that in the future, aware AI will be able to do that. But right now, agentic AI cannot do that.
Yeah, it's a great point. I mean, these LLMs getting tested on prepared vignettes that depend on a human physical exam and human curation, and then not to mention, just because you come up with a plan, it doesn't mean it's necessarily the right plan that patient's going to comply with and be able to do, and that gets to the outcome. So so many, we've just touched on a few pieces so far with these systems. So we're talking, go ahead, yeah.
Oh, no, just to respond to that. I didn't think about this till, again, the students are great and very insightful. They pointed out that, well, AI just has to be better than the average physician, right? So, not all physicians necessarily catch the hand on the doorknob moment or realize what's going on and what's unspoken. So, maybe one answer is we need to be trained to be the expert clinician, right? And the other is, I always make the assumption because, over the years, I was trained in engineering before I went to medicine. Is, technology has never ceased to amaze me. We talked not too long ago about how, self-driving cars probably always need a human in the loop. And look, we've got Waymo all over the freaking place, right? And most people I talk to, at least younger people, say they're actually more comfortable in the Waymo than in an Uber because you don't got this strange, dirty car and person trying to talk to you and ask you all these personal questions. So, and that was just, that's been over just the past few years, right? So with these discussions, I always like to think about, well, let's assume AI or whatever technology can do something in the future, right? Because, technologists would say, well, it's just a matter about data, right? Getting the right data, right? Because we have a limited data set and we tend to use data of convenience, right? Doctors' notes and so forth and so on. But at some point, somebody like Jonathan's going to collect an awesome set of data and solve this problem. Maybe Natalie, somebody, probably one of the students, and they're going to make a gazillion dollars from this, and they're going to make it so that it's better than the average doctor, right? So to me, it's still what are we as doctors? What's our role? Yeah.
Such great thoughts. And we, in 2 minutes, need to solve how we're going to get to what's our role and how are we going to train to it. So does anybody want to take a last point and just clear it all up for us and wrap it all up?
I'll make a point. I
do it.
don't want it to be the last point, though. So please, someone else I'll be the penultimate point. These technologies are here already, right? I mean, we're not debating whether they're going to be implemented. It's how we best unroll them and how we best use them. And so I just think it's really, really important now because we are at this precipice of thinking, what are the metrics that we are going to track over the next year, over the next 2 years, over the next 5 years in medical education and beyond? And I'll give an example. AI was rolled out in Stanford primary care to respond to patient messages because we get an insane volume of patient messages. And there was a paper published by many colleagues in this room that said physician satisfaction improved when AI generated a draft of the message. However, the time change was 0. It didn't reach statistical significance, but in fact, they were spending more time on messages, not statistically significant, but it was leaning that way. And so if we are enrolling these technologies that still require a physician to double check everything and get more noise and more notifications, we reach a state that we're in right now, which is why primary care doctors are working 26.7-hour days. So thinking about boring metrics, right, like time spent, is AI functioning autonomously, or is it just actually putting more work back on doctors' plates to make sure that it's doing everything correctly? Really important things to do. Now is the moment to do them, and I'm afraid if we don't focus on that piece, we will be in a not great place in 5 years.
And I would say, adding to that, is that we are at such an inflection point. It's really important that everybody here becomes actively involved in the co-creation of the next healthcare system. And this includes involving our patients also. So the co-creation needs not just to be on the healthcare physician and provider side, but actually on the community side and on the patient side. So I think it's going to be through that co-creation that we'll be able to not only have a better educational system, but we'll also be able to have a better delivery system, and hopefully by working with our regulators to have a uniform regulatory system and reporting standards that are going to make it easy for us to ensure quality.
The co-creation of that new system, which means co-creation, as you're saying, of a new education program. Celine, you've got a whole audience of future educators that are shaping your education, even though you know more than all of us already about AI. Any last words or any things that we should be thinking about how we prepare you in the next few years to go out and be a doctor?
I think Dr. Bernstein does this well in our class, but for educators to show us the limitations of AI as part of our education is incredibly important as they continue to evolve, but they're already here. He showed us an example of on an EKG, when would you shock a patient that's in VTAC? And ChatGPT said at the beginning of the T wave when that would have killed them. The answer is at the end. So just little things like that stick with you and show you that ChatGPT is not always right.
Love it. Okay, this is awesome, and I think we need to keep talking for the next 26 hours of the day. So, and then by then we'll have the answer. Is that good? Everybody good? We'll keep going? Thank you all. It was an amazing panel.